there are a number of other therapies, of course, that we're investigating for triple negative disease in the metastatic setting. It's, I think, it's good to have some additional options, at least that are in the pipeline. Claudine, do you want to mention some of these, particularly the antibody drug conjugates, sacituzumab, govitecan?
Sure. So what we've seen so far on the results from sacituzumab are really based on a phase 2 trial, but there's a large phase 3 trial, randomized trial, where we're waiting the results as comparing to treatment of physician choice in patients who'd received 2 to 4 prior chemotherapies for metastatic triple negative. But in the phase 2 trial, where the data were published, I think in 2017 or 2018, showed very impressive response rates in patients who had had significant prior treatment with triple negative breast cancer. So the objective response rate was over 30%, just over 30% in that group of patients. And I think the other thing that was notable here is there was a fairly prolonged duration of response in those patients. And the clinical benefit rate, if you think of it again, this is a triple negative patient population who received multiple prior therapies. The clinical benefit rate, which included patients who had stable disease for up to 6 months, was about 46%. So I think there's a great deal of enthusiasm about this drug. I think we're all eagerly awaiting the results of the phase 3 trial to be able to really see how this drug performs and hopefully have it available to us.
Yeah, it's an interesting agent because the toxin, we've talked some about different toxins, but this toxin is SN38, which is the active metabolite of irinotecan. So we're also targeting topo1, which is really interesting because this is an area we haven't really done much with before in breast cancer. And the data from the triple negative, single arm group has been looked at in a number of ways, but, these patients were really heavily pretreated, and the ASCENT trial that you were talking about has completed accrual. And so we're hoping to see data in the not too terribly distant future, but even more, I think, exciting for all of us is that we're hoping to hear something from the FDA on the accelerated approval of sacituzumab in the next few months. So that may make the agent available for our patients earlier. And then there's a trial ongoing in patients with hormone receptor positive disease called TROPICS, which is randomizing patients to receive sacituzumab or chemotherapy of physician choice. There's been some interest in, go ahead, Claudine.
I just want to say one quick thing. I think for those of us who have had experience with this drug on clinical trials, there's been an impressive response in a number of patients, which is, I think, what is driving, I think, all of us to be very eager for the accelerated approval for this drug to be able to offer it to our patients. Absolutely.
And then, there's also other agents that are being tested. Certainly, there's been interest in this AKT inhibitors. Priyanka, I know that you've had done some work with PI3 kinase inhibitors. Maybe just mention the AKT inhibitor trials.
Sure. So we've had now 2 randomized phase 2 trials in metastatic triple negative breast cancer in first-line setting, mainly that demonstrated benefit of adding an AKT inhibitor to a taxane backbone. And both of those 2 trials have led to development and initiation of phase 3 trials of paclitaxel with or without an AKT inhibitor, either ipatasertib or capivasertib. And they're taking different approaches. Some trials are restricting it to biomarker selected population, those that have mutations in PI3 kinase AKT pathway, and the others are more open in terms of taking all comers in first line settings. So an important area of future research is going to be trying to figure out, the role of immune checkpoint inhibition versus these targeted agents in first line setting when we're using a taxane backbone. And hopefully some of these ongoing studies will answer those questions.